This session is going to be a panel presentation which is looking to address the question, preparing for the technological revolution in healthcare. The moderator for the panel is Seema Marwaha. And Seema is an internal medicine physician at Trillium Health Partners, assistant professor at the Faculty of Medicine at the University of Toronto. She also has a master's in technology, innovation, and education from Harvard University, and most important, she is a 2016 AMS Fellow with her research focus on health communication, virtual reality, and the patient experience. And you might have had the opportunity to see her virtual reality simulations in the library. It's been available for the past 2 weeks. She recently completed the Monk Global Journalism Fellowship Program, and as a part-time freelance journalist, her work has been featured in CBC, Quartz, Vice, Maclean's, National Post, and Chatelaine. Please welcome Seema.
Thank you guys so much. I'm so excited. So this panel is going to be entitled Preparing for the Tech Revolution in Healthcare. I'm excited to share the stage with this very esteemed panel who I will introduce in just a moment. And as you guys know, so I am past 9 months pregnant. So pregnancy is actually 40 weeks, which is more than 9 months. So I'm past 9 months. But these are the last 2 hours before my official mat leave, actually, as well. So our first panelist I'd like to introduce is the Honorable Kelvin Ogilvie. He's a leading expert on biotechnology, bioorganic chemistry, and genetic engineering. He is the inventor of the drug ganciclovir. He also developed a general method for the chemical synthesis of large RNA molecules and was admitted to the Order of Canada in 1991. He was appointed to the Canadian Senate in 2009 and chaired the Standing Senate Committee on Social Affairs, Science, and Technology. Welcome. You guys impressed? Wait till you hear about the rest. So Will Falk is a retired partner with PwC. He spent 25 years as a strategist in New York and Toronto. He is an adjunct professor at the Rotman School of Management at the University of Toronto, where he teaches a course on innovation in healthcare. And he is an executive in residence at Think Research and works with a couple of software companies advising them. Please give him a round of applause. And then, as you all know, Stephen Klasko, who was introduced earlier today, but just as a reminder, he's president and CEO of Thomas Jefferson University and Jefferson Health. And he's also a pilot and a DJ, and fortunately for me, an OBGYN. Welcome. And then we have the very brilliant Aimee van Wynsberghe, who just spoke before the break on healthcare, robots, and the good life. She is an assistant professor in ethics and technology at Delft University in the Netherlands. Welcome back to the stage. So why doesn't everyone have a seat? And while they're getting settled, just one more round of applause for these panelists. So I think what we're going to do is we're going to start just with a directed question for each panelist. And then obviously as a panel, please respond if you guys have anything to say. So the first question is for Kelvin. So integrating technologies like AI and robotics into our healthcare system can be very challenging. What regulatory environment do we need to push forward with this vision?
Well, one that suddenly stimulates Canadians to the Canadian healthcare system to actually recognize the I thought it was going to be. Is it on now? Good.
Thank you.
Well, if I understood the question correctly, the first critical thing is stimulating the healthcare system to actually recognize that this is critical for their future and to be able to adapt to this and adopt it and to implement it for the benefit of Canadian society. It's going to have an enormous transformative impact.
Got it. And And from a federal government perspective, sort of what do we need to do to prepare to make these changes?
Get people in the critical roles in government who actually have the capacity to understand how important these things are to the future of this country, and to recognize that we are the world's second largest political landmass in the world with a population only the size of California, and that we have to do things differently than in other countries in order to get the critical mass together to actually take advantage of these. During my career, spanning all of the technologies, we have been the worst country in the industrialized world in terms of the translation of fundamental research into social and economic benefit in Canada.
When you chaired the Standing Senate Committee on Social Affairs, Science, and Technology, my understanding is that there was a report that came out of that work. So what were the major findings that came out of that report that you'd like the audience to sort of take away?
Well, the major findings we did 3 years ago. I convinced the committee to appeal to the Senate to encourage us to do such a study. We did that, and a year ago our report came out on artificial intelligence, robotics, and 3D printing. The three are integral in terms of the overall application of these technologies to the healthcare systems. And the major issue that we identified is that in order for Canada to take advantage of this in Canada and get the major advantages from our basic research, Canadian researchers we recognized and identified are the world's leaders in basic AI research. But to translate that into social and economic benefit in Canada, we have to actually find ways to take the great enthusiasm of it, like we see here, and move that into actual implementation. That doesn't happen by accident. And so our report focused on how could the Canadian government actually take the leadership to ensure that Canada and Canadian healthcare system, we don't have a Canadian healthcare system, that, Canadians could benefit but from improvements in a healthcare delivery in order from this kind of technology. And that has to be orchestrated. It won't happen by accident.
Are there any comments from any of the other panelists on regulatory environments needed to push forward with technology and the technological revolution?
Yeah, I think we need regulations, but we also need to be careful what it is that we're regulating. So we don't want to prevent industry from going forward in certain respects, but we want to make sure, and also there are a lot of regulatory tools out there that will protect us in the AI space already, but we need to be careful about what new things we need. So one thing is we need to know when we're interacting with an AI. Right, so the Duplo came out, Google's Duplo, and this was, I mean, it's incredible when you're listening to this thing and you have the human and the machine interacting, but we also, I was showing different pictures of chatbots that are coming up, so it could be that we need regulations that are very specific to AI and that can ensure that individuals know when they're interacting with an AI, with an algorithm, or with a human person. So I think, at least in the European context, we have regulations, we have the GDPR to protect us in terms of data, but there are now unique instruments that we need for specific AI-related issues.
I mean, I think the biggest problem is who's doing the regulating. I mean, in the United States of America, they were talking about all the stuff going on with Facebook and Google, and it was clear that the folks in the Senate, other than looking at their grandkids' pictures, had never even used any of those things. And they're the ones doing the regulating. And then, and obviously we're not going to leave it to Mark Zuckerberg. So the question becomes, ideally you would have a bunch of Aimees getting together and saying, this is the new world. Because you're going to have the lobbyists trying to get no regulation, getting back to the example I gave about Intuitive and the robots, and then you're going to have folks saying we need some regulation. You don't want regulation to be a roadblock to where those things can be helpful, especially in health. So I think it's going to be a very fine line. To me, ideally, you would get a panel together that really understands this, that would be trusted by all sides.
So we're doing that in Europe. Sorry if I can interrupt. So we have this high-level expert group on artificial intelligence, and our task is to be, there's 50 of us from all over Europe, from industry, from academia, from consumer rights organizations, and our role is to think of what kind of regulation should we have that won't stifle, that will be, empowering, who is responsible for it. So we're at least starting that. And I know in Canada, I'm right, the Toronto Declaration, the Montreal Declaration, so there is also some movement in Canada to do a similar thing, to have the public groups coming up and saying, this is what we need.
That's great.
Absolutely. I think Kelvin had one more comment before we move on.
Well, if there's a concept that our report is about regulation, it is not. It's about how to build the capability in Canada to actually take advantage of this and move it forward. Regulation, governments are involved in regulation. It's perhaps natural to think that we senators were involved in regulation in this particular situation. That's not the case at all. This was an effort to give Canada a structural basis to actually move the issues forward because, by the way, as an example, this morning Stephen described total capability of his university at the center of a group of collaborating institutions with formal and informal regulations that overall has a total capacity in this area greater than our entire country does. We cannot allow it to just go ahead without some body, and we don't have any major companies that are capable of looking at it nationally in order to translate the genius research that is going on in this country into social and economic benefit in this country.
I think so. I have next a question for Will specifically, and anyone can comment after that. So a lot of what this requires is the embracing of change. And how do you see the role of the health provider, and that can be any health provider, changing when AI technology is more widely available?
Yeah, so first off, I'm really delighted to be up on, really enjoyed the day. You guys were so impressive today. And a big shout out to AMS for putting on such a great day all day long. I just thought it was wonderful. I in thinking about this panel, kind of have been looking at AI as one example of technology change over the course of the year. And my first observation would be, don't panic. We're all using AI all the time, whether we know it or not. And at the moment, at least in healthcare, most of the machine learning and artificial intelligences that we're using are still human supervised, and I think are likely to stay human supervised for some time, by which I mean that things like ECG systems, which are an artificial intelligence that we rely on, are human supervised algorithms that we use in the course of practice all the time. And I think we're going to see more of those. That isn't to say that there won't be a lot more deep learning and machine learning brought to big data sets, just to say that I think for the near-term future, what we're going to be involved in is a process of figuring out how we bring that into life and practice. I do think that it will be along lines that we've already all been thinking of. So, things like social determinants of health, the scope of practice issues that we've dealt with over the years, questions of appropriateness, all change as technology and artificial intelligence and specifically come into play. And I loved some of what each of you said on some of those topics, so just riffing off them for a moment. I think appropriateness is probably our biggest near-term danger. The ability to mistune algorithms to a very high false positive rate in the interests of, screening people means that we have the ability to create big electronic PSA tests, which on a population health basis will not be positive. And you see the dermatology example, I would push on that one and go specifically into some of the nasty stuff that's going on in Florida right now, where you have free screening with very high sensitivity, resulting in very high false positive levels being turned into Medicare visits, right? And so that's a great crystal example where you've got a really good technology, because I, for one, think teledermatology is a great idea, although I know there are others in the room who are more expert on it than I am. But it can be used for evil as well as good, and we really need to think about that. On the social determinants piece, I know that I used 3,984 calories each day in the last week. I know that I slept for 7 hours and 44 minutes. I could give you my respiration and breath patterns and my blood pressure and my heart rate if you want. More generally, whether my mom opens her fridge by 10 o'clock in the morning or not is a darn good indicator on what kind of day she's going to have. And the IoT in homes is going to be huge, particularly with voice activated. So the ability to do different things around social determinants is really exciting. And I think important, and then I'll just close by saying scope of practice gets revisited, because with prediction algorithms, we can sit at the top of our scope of practice at every skill level. And while I don't think that the vision of a doctor in the patient's pocket is realistic, I do think that every nurse I've ever met would like to have a doctor in her or his pocket. And I do think that that's realistic. And the scope of practice of predictive medicine, I think, is exciting.
I would just add briefly that I think that we have to be honest with providers about whether or not this is really helping them or not. And I think the EMR is a great cautionary tale. I'm getting you an EMR, isn't that great? No, it's really not great for me. It's actually giving me less little human. I used to sit next to obstetric patients. By the way, Will ratted you out that the only reason I'm here is because I'm an obstetrician, not because I know anything. But that literally, that I used to literally sit like this. Now you're sitting by a computer. EMRs are the first thing ever that required more humans, technology that required more humans just to get you back to where you were. Usually it's just the opposite. And I think the same thing is true as we start to use some of the things you're talking about, Will, with consumers. I mean, I know some people that are absolutely obsessed with how many steps they get. Oh, good, I got to my 10,000 step as I'm going to Ben & Jerry's and having my third Jello.
And
so
my doctor is polite enough to listen to me when I tell him how many steps he was doing, but he views it as part of the introduction to the actual medical visit.
To the whole health piece, yeah.
Awesome. Any other comments?
I was going to say the calculating the number of steps and all of this medical data, it's so fascinating because it provides us with, a brief glimpse into how we're doing, but it's actually really valuable data for the companies. Like, they turn around and they create products and they train products and they do things with it. And so then this goes back to one of the questions that was asked of me about, the sharing of data and just ownership of data. Should we be rethinking who is the owner of the data, and should you get more benefits out of sharing the number of steps that you take, or your heart rate?
Well, it'll be really fun to watch in the next few years as the price of the genome goes negative, right? Because the genomes are now so cheap that I think that we're going to enter a world in which people will be paid to do their genome. And once people start realizing that there's that much information value, then I think some of what you're talking about will go. At the same time, I'd be inclined to go and live in Sidewalk City. And I know that makes me like, Sidewalk Labs. Like, I'd be inclined to go and live there. I know that makes me like vaguely Orwellian or something, but I'd be kind of curious to be one of the first people who they knew everything about. I don't know. I mean,
so let's just play off that for a second.
I certainly would like my mom to be there. Sorry.
Yeah, I was going to say let's play off that for a section. So for a second. So you mentioned Facebook. And people got very upset with the idea that their Facebook data was used in ways that were unintended. So for marketing, maybe perhaps to influence the election. Jury's still out on that, I hear. But
Is the jury still out on that?
Oh, what?
Well, I don't represent the whole United States of America.
you do on this panel.
And right now, I'd rather come from the Netherlands. So let's,
By the way, the jury's still out on everything in the U.S. as far as I can tell.
That's the story. But there's this whole sense that people were volunteering all this data without even considering how it could be used in the future. And so how open or comfortable should we be or not be with our health data being accessed by government, third parties, industry, knowing that what we give up now could be used in ways maybe not even thought to us in the future. And any thoughts from any of the panelists?
we just did a partnership with a company called Color Genomics, which is part of that Silicon Valley partnership we have. And part of that is that we offered all 30,000 employees full genomic and subtype testing for free because we're self-insured. And I'm getting that ethics look from Aimee, but
she's giving him side eye.
But yeah, I got that look. No, and part of it is because there's 5 different areas where they've looked and said this can really these subtypes can make a difference. So, for example, there's certain
Save your company money.
Well, save my company money, but also so there's certain subtype of people that if they're that subtype and they're depressed and they're on a serotonin agonist, it's not working. So that means you have some depressed people that are literally taking this medication with all its side effects. It's not working, they're still depressed, and we're spending a lot of money. So the issue becomes, and they were willing to go totally at risk based on outcomes. So the question, what's interesting is 90% of the lower level employee, when I say lower level, people making under $50,000, $60,000 said, cool, great perk. Only 10% of our faculty opted to do it because they said, they had all these questions. Well, what happens to the data? Are you going to use this for tenure decisions? Are you going to? And I was stuck with, trust me, I'm the president, which didn't really go that far. So I think that the more and this kind of stuff that happened at Memorial Sloan Kettering with that data is again a cautionary tale. So everything we talk about has ethical risks, and I think people are getting more and more. And I should say less and less trusting that their organizations, certainly they don't trust Google, they don't trust Apple, they don't trust Facebook, they don't really trust the government, and they might not even trust their employer that you have my genomic or IT information.
I don't think anyone should be surprised by this, right? Like, I mean, Banana Republic has long been willing to pay me $200 for me to use their credit card, and I get a cent and a half kickback on every dollar I spend from Visa. Information has value, and we have to understand it. The one great big misconception that I sometimes hear, though, is that my data is a whole bunch safer if it's held by public institutions, which is absolutely not true from a number of different ways. First off, because many of this collection in one place of large quantities of data makes for very attractive targets. And this idea that you can have a Maginot Line and defend them, I think is pretty misplaced. I think where we'll end up actually is to go back to patient and family controlled records that you give access to, and I'm very, very skeptical about this idea that my information is safer in the hands of either a big company or a government without me having that control.
Look, the real answer is that you have your records. They're in a totally secure cloud, and if you decide to no longer see me as your obstetrician and go to somebody else, you shouldn't have to go to your doctor to say, could you please send the records? You just change your password, right? If you go from Citibank to Bank of America, you don't have to ask Citibank if it's okay. You literally go and just do it and you change your password. And we've actually looked at some companies, the thing on that would be, okay, I get that, but what if I end up getting run over by a bus on the way out here and I'm in an ER? how can they get my records? And what hospitals and providers would have is some fail-safe things that could open up anybody's records, but that would be very much audited. You know, just like you would audit level 5 drugs. You know, wait, you used 5 things in your trauma center. We need to know that all 5 of them were legitimate. But I think, to me, there's no reason that shouldn't happen. In every other thing, you own your data. Why shouldn't health be like that?
Yeah.
I think that, from my perspective, through my life, that's always been the key. I started demanding the results of my blood tests and so on nearly 40 years ago. And I had to fight like crazy to beat them out of the doctors of the day, because that wasn't my right to know what it really said. But I did. I won. I got them, collected them. I have my own database, and I will protect that absolutely. Will I transfer that to anyone else? No, not unless my life is threatened. And so I have considerable skepticism about the systems out there. But I think one of the really big things we are facing is what information that we read in the ether of news and et cetera we can rely on around any of these kinds of issues. And I think that we are going to go through a transitional phase. It may take a decade or so. But out of that will come a new way of dealing with things in a much more personalized sense and personal control that will enable us to take advantage of the great progress in access to general information without totally exposing ourselves to every parasitic thought that exists out there in the big wide world. And I think we have seen in political issues and other issues in just the last few weeks in this country that it is absolutely essential for individuals to take complete control of their information and have the good sense, regardless of their titles, to protect their information extremely carefully.
More comment?
Yeah, so I wanted to say 2 things about the idea of the data collection and what it's used for. And the first thing that strikes me is profiling. Right, so all of this data is used to generate a profile of an individual, so you have a kind of digital you out there.
Footprint, yeah.
Yeah, and then what is this profile used for? Right, in the more benign situations, it's used for marketing. It's used, you get a recommendation on the next book that you should buy based on your previous purchase history. But in the other more serious situations, this profile can be used for whether or not you get mortgage application approval, whether or not you get admitted into a certain university, recidivism, right? It's also used in the United States for recidivism purposes too. So there's the profile becomes this tool to make decisions about you, and you have no chance to correct the data or to go back and to verify the data, right? Data provenance is a huge issue. So I think that's one thing that we need to consider. And then just picking up a little bit on the genomic data that you were talking about, that's one instance where the impacts of what happens to that data, so whether it's hacked or whether it's whatever, aren't just about the individual. Right, so my mom's genome will give information about me. So I think this is, we also have to consider that the profile and the data that's collected about us isn't just about us. It's about the people that are in the house with us or that are related to us and share a bloodline. So the data, we need to be so careful and specific and private. Yes, we need to have complete control over this data. And those are the 2 reasons that I would put on the table for that.
Well, I have a question specifically for you that riffs off that a little bit. So you mentioned distributive justice in the talk that you just gave us, and I think, Will, you mentioned social determinants of health. And so one thing that has been crossing my mind with all of these talks is, will AI and robotics exacerbate or eradicate the existing inequalities we already see in our system?
That's, yeah.
Yeah, Amy, what we'll do?
Yes, Amy.
Please discuss. 45
They're getting
seconds,
tougher,
please.
guys.
So I think I don't want to be the Debbie Downer on the panel, though, that it's going to exacerbate the problems. But I think in some ways it is going to exacerbate. In some ways it might eradicate certain issues, but I think it will exacerbate. And the reason why I say that is when we think about issues like environmental awareness, sustainability issues, think about the processing power, right? Think about the data storage warehouses and where they're being built and that kind of thing. So environmental considerations or There are companies that go over into developed countries and hire people to label all of the pixels on an image, and this data is what is used to train systems for autonomous vehicles, that kind of thing, right? So we're talking about going into countries that are already broken, the infrastructure is broken. We are, in our very paternalistic way, we're going to provide them with jobs and that kind of thing. And then what do we do when we don't need them anymore? We're going to leave and move on to the next group. So I think we're seeing we will exacerbate certain environmental whatever problems, but we're also going to be creating new problems that we have to be transparent about and think about. Maybe we're only allowed to go into a developing country and hire these individuals if we can ensure that it is a long-term situation and sustainable.
So I think we have to really be careful about, I don't know another word for it other than the NeoColonialism, because I think we often misread these situations. I had teams working for me in India for many, many years. I'd say on average, my Indian team was higher skill level than many of my Toronto teams. And sometimes they did the kinds of jobs you're talking about, particularly multi-surfing. But the number of those young men and women who have ended up in really like it's the American dream in many ways. And then to use a nursing example, I mean the Philippines and kind of what's happened with Filipino nursing, where they graduate 8 times domestic demand, and send them over. I think there's some interesting stuff there. I would just say, and I'll tell I think that some of this, back to the screening piece, I think some of this stuff will cut in different ways. I used to be forced by my employer to use one of the concierge medicine places in town, where I'd go in for a 4-hour workup once a year. I'd get ultrasound, a stress test, a hearing test, et cetera, et cetera, et cetera, all of which was supposed to be great for me, right? I used to get doctor's notes to not have to do it, so that I didn't have to have all the useless testing. I actually think that a lot of this new algorithm stuff may end up hurting the wealthier people, because they'll grab on to all the new useless toys and screen themselves out of existence. Or screen themselves into over-treatment. How about that as a more balanced way of saying it? Because now that the worried well will be able to, find every idiosyncrasy.
I had just one question for Stephen. So we heard from you today how augmented intelligence, machine cognition, virtual reality, all of the good things that it's going to do in terms of improving health. But what I want to know is sort of what can't it do, and what are the blind spots that you see that we can maybe briefly discuss?
Yeah, there's a great quote, I forget who said it, but we tend to overestimate technology in the short term and underestimate it in the long term. And I think that's what's happening with AI. IBM Watson is going to replace radiologists. I mean, or pathologists. I mean, that's not going to happen. So I think the first thing is getting away from the term artificial intelligence. It's really augmented intelligence from what we're doing. The second thing that I think, that we really have to recognize as a blind spot long term is humans and robots are going to have to interact. And there's going to be certain things where robots are going to be rolling their eyes, I can't believe the human's doing that. I mean, we haven't even, it's been 100 years, we haven't figured out the doctor-nurse thing yet, let alone putting a robot in the mix. And I think the reason that will matter is, I was on a panel with the guy that runs Google X. And there are certain things where it's better, frankly, that humans aren't involved. And he was using autonomous vehicles as an example. And he said that the only accidents so what happened is the way autonomous vehicles were before I got to drive in one of the Google cars in the back seat is if something went wrong, there would be a loud noise, and the humans in the back seat were supposed to take over and do it manually. Well, what happened after a while is, they'd have their headphones on or if it was a couple, they'd be doing some things in the back that, you know, what's that, honey? Oh, that's just a loud noise. Don't worry about it. Crash, you know? So literally what they decided is in that situation that there would be no human piece. If anything went wrong, the car now goes off to the side of the road, calls for help without any human interaction. I think, by the way, the same is true in pilots. So I think that we will tend to think, oh, I can't wait till, you know, artificial intelligence comes, and then we'll be disappointed because in a year, 2 years, 3 years, it's not going to be all we think. Second thing I think we have to worry about from a blind spot is what some of the negatives are. The virtual reality stuff is really pretty amazing. We're working with a company around opioid abuse with virtual reality, and another one around cancer with hospice and virtual reality, of putting people in a different world. And it's really pretty positively addictive for those folks. But what about for other folks? What if it becomes like the video games in the 80s where that's all, you know, teenagers start saying, you know, hey, I don't want to live in the real world. I just want to live in this virtual reality world. You know, what are those negative implications? There's another company we're working with called MindStrong out of Silicon Valley that does digital footprinting, again, if you opt in, for people with serious mental illness and substance abuse. And basically, they're getting really good at basically, based on all your Facebook things, are you about to go over the edge of starting to shoot people? Are you about to go, you know, from being in a substance abuse center to being under the bridge? The problem is you're sharing a lot of that, to all the points we made, a lot of that data, and what if they're wrong? You know, so I think we're still going to be at 1.0 in a lot of these things, even what I brought up with the HomePods or the Google Brains. If you remember Siri when it first started, it didn't understand. She didn't understand anything you said. And you know, it's almost been like the telebanking thing. Over 3 or 4 years, in its 87th iteration, it's pretty good. But as we start to get Siri involved with health, it'll take a while for it to be pretty good. And when it's not good, it can do more harm than good.
Could I pick up on that? The Siri thing and how it wasn't so great at the beginning. I think that's really important for us to remember that we're almost kind of engaged in a social experiment with these technologies. We experiment with them, we help build them to the next stages, and it's almost like that needs to be part of the discussion. What does it mean if this is just an experiment that we're all involved in? What are the conditions? What are the limitations that we should be putting in place? But there was also one other thing that I wanted to touch on. Oh, the opt-in. When you said right now it's opt-in, yeah? It's opt-in until it isn't, right? And something that I didn't touch on in my talk, you know, I was talking about informed consent, and what I also wanted to emphasize, you know how when you want a new app on the phone or you're going to a website, do you agree to the terms and conditions? Right? So this is informed consent in action, yeah? You agree to the terms and conditions, and if you don't have the app or you don't have access to the website. So it's almost like informed consent is meaningless right now. The idea of opting in is meaningless, and we have to make sure that that is not how we go forward with AI and then, you know, linking it with the profiling. If all of this data can be used to make a profile and there are real-world consequences of these decisions, we have to have real informed consent, real opt-in mechanisms.
But Aimee, the problem is going to be if you take a system like Canada's where you're offering health care to everybody, and let's say there is an AI technology that really starts to affect the outcomes and the cost and the quality, and a group of people says, you know what, I'm not going to do that. That getting back to your affecting other folks, that affects other folks because those folks aren't opting in for something that would really help them provide the best care for themselves at the lowest cost, which means that there's going to be less to do for other folks.
But isn't that the foundation of a democratic society? Like, aren't we allowed and free to make choices about whether or not we want to be a part of these things? Like, isn't...
Well, except that, yes, and that's always been the United States thing with healthcare of, look, we can't guarantee access to everybody, but you can get the platinum thing or the gold thing, but that creates a different kind of imbalance of people having to mortgage their house if they have cancer. But once you say, I'm going to be in a society, democratic or otherwise, that says everybody has an equal right to health care, in some respects you are giving up a little bit of that because it's sort of the what's good for all is more important than what's good for
Great.
the
But- Greatest good for the greatest number.
But we have those differences already.
Yeah, vaccinations,
And some of those differences will be made better and some will be made worse by artificial intelligence. I think of the urban-rural split in terms of care delivery and the way that that will even out in some areas as we bring augmented intelligence, I'm going to use your term, back in. You know, will there be places on the edge? I'm from a Mennonite heritage. I mean, we've always had Luddite groups that opt out, and we do view that as the right of people in a democratic society, right?
So I just wanted to take one moment. So Kelvin actually has some prepared comments that he wanted to make that I was supposed to allow him to make at the beginning, which I didn't do. So before we break for audience questions, I was just hoping that we could get to that piece. So I'm just going to give him the floor for a second.
Well, thank you. Obviously, probably because of my age, I misunderstood the instructions, but I thought I came here with the understanding that we would have opening remarks and so on. And there's a couple of things that I would like to say as a result of that. First of all, the conference here today was, will AI and technology save compassion in healthcare? Well, I had a couple of comments to make about that. And first of all, compassionate healthcare involves, from the technical point of view, timely and accurate diagnoses and effective treatments. In order to deliver good health care, you've got to deliver that. AI, robotics, 3D printing combined are certainly going to have a dramatic impact. I'm looking at things from the positive point of view, on the ability to detect rapidly, to identify the appropriate response, and to implement it effectively. Now that should allow the healthcare provider to be truly compassionate to the individual, because nothing makes the patient happier than to get a rapid and effective diagnosis or accurate diagnosis and an effective treatment plan laid out. However, compassion is generally attributed as a human virtue, not a mechanical virtue. So it's got to be added by the practitioner. We know that other living species have shown signs of compassion, but we generally attribute it to ourselves. And so we are going to have to work on that piece, as Stephen and others have said during the day. But I just would note in this regard that if puppy dogs can detect cancer, just imagine what AI is going to be able to do for us in terms of where we go down the road. And the second thing I was going to do, which I'm going to dramatically shorten up, was because I was asked to come and comment on our report from the Senate. And I wanted to tell you that the question that was asked here today at the end of the general session, where all that excitement about how we're going to move forward in this area was created, that doesn't get translated into action by accident. You have to have a mechanism, a capability of taking ideas or even general enthusiasm into application. And so what we did 3 years ago in convincing the Senate to let us do the study on robotics, AI, robotics, and 3D printing was the awareness that this is going to have profound impacts on our society. And I want to remind you again that the IT revolution, and it was, those of you who remember 30 years ago with the expectations and predictions from IT, we're 30 years in, and every year things get more exciting in terms of the applications that have been developed. So, the AI, robotics, and 3D printing revolution is going through, as I think perhaps Stephen said, the dramatic excitement phase right now. But it's going to linger over a long time in terms of the applications and working out the kinds of issues that Aimee and the others have described here today. So what we attempted to do in inviting all the Canadian experts, international experts, to the Senate committee to study where this will go and try to give a recommendation as to how we can benefit from it in Canada was to develop a mechanism in this country because, as I indicated in my first comments, we are unique in comparison to other countries. Europe countries may not have a whole lot of population, but they're small and compressed, and they're close together. Critical mass is a really important issue. You can do it today virtually in addition to real, but it really helps to have the kinds of operation that Stephen described today. So I'm not going to go through all the recommendations, but I just want to tell you, and you can get this online, and please don't worry about these first few slides because we've discussed all that kind of thing. But we felt that, and by the way, I was a part of the biotech revolution and part of the scientific community that had, in each country, there was a biotechnology strategic committee set up. And there was an international one that representatives from each country went to. And the scientists themselves at the Asilomar conference came up with the guidelines of how genetic research should be treated. And those regulations, recommended by the scientists themselves, are still the basis of how the world operates in terms of ethical use and development of those kinds of things. And so my recommendations, or in the committee's recommendations, are based on the experience that we've gained over the past time. And so we felt that the critical thing was having a national conference pulled together with the experts within the country and perhaps elsewhere, and all of the key stakeholder groups, as Aimee was talking about, I think in some respect, with regard to the knowledge you've got to bring together in order to develop a plan. And in Canada, we've got to have a national strategic plan as to how to move forward on this. If that doesn't happen, we're going to lose out in many ways in this as we have in the others. And so just to indicate some of the topics that we felt needed to be discussed at this national conference. By the way, we're not talking about people sitting around for weeks doing this. We're talking about a hard-hitting, fast-moving, deliberately focused, get it down and move on with a strategic plan to build this in the country. And we've got the issues that you've all been talking about. And at the bottom, we do understand that regulatory oversight also has to be part of the consideration that we deal with in these kinds of things. The working groups that would come out of each one of those sessions would then be charged with moving things forward. So thank you. I'm not going to go through and give you a few more slides on how we thought that that would impact, but I just want to say to you that in this report that's available, of course, online and whatever else, we laid out a strategic plan for moving forward in helping Canada really deal with this for our society as this incredibly impactful technology. There's actually really three major technologies together that are going to have the potential to bring great benefit and will be subject to great abuse. And we need to have a strategic mechanism for doing this. Canadian governments have shown little instinct for using their leadership capability to develop national strategies in any area, obesity, dementia. None of these areas do we have strategic capability. We are, from all the studies that I chaired in the Senate of Canada, we are, as everybody in this room says, we are a country of pilot projects. And we don't even have the capacity to put the results of those up on any national website, such as PIAC. They won't even put the things on the website for the best models for dementia, obesity, and, of course, in this particular area. And if those of you who have read the minister's response, in Canada, the ministers are required to respond within 90 days to reports of the Senate directed to them. I suggest you read that response, and if you have confidence that Canada is going to move forward to deal with this issue, I would be extremely surprised when you read that response. Thank you.
Pretty powerful call to action. Do we have any quick responses before we go to audience questions?
I have a question. I wonder what can the average individual do if they read and they say, no, Canada isn't ready and Canada needs a national strategy. And then what do you do? Do you apply pressure on local government, or do you, I mean, is there, what do you do?
Like the individual call to action.
Well, I think individual call for action is gaining increasing momentum in Canada and in a number of areas. For example, we still have a lot of the medical profession that claims that Lyme disease is not a real disease. And, you know, people tried to operate through the general route so far, and now it's gone to the grassroots where they're taking it to their local member of parliament, their local MLA or the equivalent in provinces, and are trying to move these issues forward and are running into tremendous opposition. So I think in Canada that is going to be one mechanism as we go forward. I still believe that the country has got to plan strategically, in not just this area, but many areas. And I'm still hopeful that we may be able to convince either a province or some large, and here in Ontario you have the greatest collection of pilot projects in the country, many of which have yielded really good results, but there's not even a place to display those kinds of results in the areas that they occurred. That you have the biggest population and one of the most advanced populations that could lead to a significant momentum of public movement forward, and you have tremendous research and medical resources in this province.
Thank you. So why don't we take this opportunity? I'm sure the audience has quite a few questions. So I think there's some people circulating with mics. So can you just raise your hand so we can see you?
So thank you very much, and to whoever that said that doctors and nurses have not figured out, we love one another. So absolutely we do. But on that
Come
note,
to my hospital.
On that note, Senator Ogilvie, Lyme's disease. That's actually our neo-nurses, Sue Faber, and all of them that are pushing the social movement. Would love to speak with you after. The issue of Lyme's disease that actually finally Health Canada is listening. But there are exceptions. I don't think all is gloom and doom, and I want to give an exception, which is supported by government of Ontario since 1997, which is the best practice guidelines and the best practice spotlight organizations. I see my colleagues nodding. Over 400 in this country and about 350 across the world doing knowledge mobilization with outstanding outcomes. Now, that's not artificial intelligence, but we are in conversations with U of T department to actually look how can we produce in-time knowledge based on that massive database that now we have of users. So I just want to keep a little bit of hope that in some instances, governments, all parties actually see the light of the day, and hopefully they will see that with Lyme's disease too, because it's costing actually lives.
Well, I think there are clear examples where individual areas of health have been moved forward dramatically by the practitioners and the patients overall. And if you only have to look at the Heart and Stroke Foundation to see an example of a situation that came up through the grassroots to lead ultimately to tremendous advice available to the population in this country the minute you're identified to have any symptoms of stroke. But contrast that to the totally contrary position of somebody who is initially diagnosed with dementia and is told essentially to go home, close the door, and wait for the inevitable.
I'm actually reasonably jazzed by what's going on in Canada right now in this area in terms of stuff that's going on the ground. Where I will totally agree with my colleague on stage is that waiting for national leadership is just a waste of time. I used to do it, and I used to care, and I used to show up on those discussions. Now I just absent myself from those discussions because they're a complete waste of time. So focus on getting stuff done on the ground and keep moving, and don't worry about the national discussions because it won't be a positive.
Hi there, thank you very much. I'm Gary Block, I'm a family physician just around the corner here, and one of the AMS fellows. I just want to push a little bit on the equity question. I'm quite skeptical, actually, about the ability of technology, robotics, AI, as we know it, to truly improve equity. In fact, I'm more than skeptical. I'm actually quite worried that it will worsen inequities. And I just wanted to, I'm just going to throw out a bit of a question, then see where it goes. And just say, often when we talk about inequities, we talk about things like, do people have access to smartphones? Fair enough, that's a very obvious one, very easy one to remedy. That's not really where I want to go. I think a more interesting level is whether or not AI and other technologies can actually reinforce the kind of biases and prejudices that we have in society in ways that we may not be anticipating. And I say this partly as someone who has struggled within our healthcare team to find ways to, for instance, bring in the voice of people who have been traditionally voiceless in the health system, in our planning, in our thinking. And then I think about AI coming in, which is generally, I think, technology that's been developed in places like Silicon Valley, places that, by teams that are probably not reflective of those voices we've been trying to bring in. And algorithms that these things are built on are human-built algorithms, right? And I have already started reading things about how these types of algorithms can reflect biases and prejudices. And is this going to be an insidious way that we will start to take steps backwards in the work that we've done? Can we counteract that? Is this being thought about in the world of ethical thinking around this, and in the world of development thinking around this type of technology in AI? And are there ways that we as frontline practitioners can work against those trends to try and preserve the progress that I think we've started to make on this front? Yeah. Simple question. Go ahead.
Yeah. That's a really great question. And actually, you're absolutely right. The biases are most definitely finding their way into the resulting algorithm. So I think that's been shown now in a variety of different applications. I'm not sure if you heard of Amazon. They just stopped using their latest algorithm for recruitment of individuals because it showed that they were hiring more males than they were females. And there was all of this talk about, the algorithm is biased, the algorithm is discriminating. But the algorithm was learning based on the practices of the company that were already in place. And that is why training data is so important, because all of the biases that we have culturally will find their way into the algorithm. So that is something that we've known now for, I think, about a year, maybe a little bit longer. And the message is gaining momentum. And now there's a lot of talk about diversity on the teams, a lot of talk about diversity in training data. So even when we're talking about skin cancer detection and the fact that the AI can't detect different tones outside of Caucasian skin tones. So there's a lot of talk about how we can move that forward. Inclusion is the big buzzword of the day, that it's all about including diverse perspectives on the team and cultural experiences and so on and so forth. So there is a little bit of promise that, there's a glimmer of hope in that we get it. I would say even Silicon Valley is starting to get it and is trying to do something about it. But that's my perspective.
Yeah, look, I think inclusion is the right word, because when you think about whether it's AI or even research, we didn't do heart research on women till about 30 or 40 years after we did with men. So miraculously, there was a lot more progress made with men. I think that it really gets down to motives. I guess I have the half empty, half full thing of AI can be a tool for either, depending on what the motive is. So the example I gave, by the way, on choosing students based on holistic criteria. We didn't do it for this reason, but in our country, in 1978, 4% of matriculating medical students were African-American males. We doubled down on everything that didn't work, so that in 2016, 4% of matriculating medical students in American medical schools were African-American males. What's interesting about the holistic criteria thing, it wasn't necessarily meant to just be a diversity thing. We quadrupled diversity compared to the rest of our class. Boston University has had the same experience. Why? Because there are people in Philadelphia, Pennsylvania, whose moms or dads pay literally $150,000, so little Johnny or little Mary can memorize that Krebs cycle really well with 7 Princeton reviews and 5 tutors so they can become a plastic surgeon in Sarasota. Then there's another kid that really just wants to go back to West Philadelphia and become a family doctor that has a battered Barron's book. You want to talk about tale of two cities. When we start to choose students based on self-awareness, empathy, communication skills, cultural competence, it becomes even. I think the same is true when it gets to artificial intelligence or augmented intelligence. There will be a lot of reasons to accelerate the greed and the inequities, and you could be right. But I could argue if Jeff Bezos really wanted to do something cool with AI, he could look at the food as medicine thing, which is one of the big issues, at least in our area, where the places that have those really bad health inequities might have a bodega, and there are 3 Whole Foods in my zip code, where he could say, wait, we got Amazon Prime now and Instacart. Maybe we could work with government, and we could AI healthy food, and people that are willing to buy healthy food, we could Instacart over to them, and we'll give them 1.5 times the dollars of the electronic food stamps if they get healthy food for their families. Because, by the way, people want to get healthy food for the family. They just don't have the gas to take their car over to the Whole Foods, because Whole Foods decided not to have it there. So I think you could use it. Am I optimistic that that either government or Jeff will necessarily do that without a push? Not necessarily. But I do think, just like with everything else where we're coming to a tipping point, I think we're going to come to a tipping point around the health inequities. And I think what you're starting to see with the backlash, even on the stock price, with the Facebooks and the Amazons and everything, will, whether for the right reasons or wrong reasons, force them to start looking at using some of their technology the right way.
The health equities point absolutely bears watching, and I don't think we know yet which way it'll be break. I heard a fascinating discussion on Aimee's example, or a related discussion to Aimee's example, around why more men were responding to STEM ads. And the conclusion, this was at the Creative Destruction Lab over at U of T, and it was very interesting because the reason the algorithms were misperforming in that situation is that men are cheap. That when you buy AdWords, men are cheaper than women. And so what was happening is that the higher price ads were pushing the men out. So the ads the men were seeing were the STEM ads.
Are we cheap or more gullible?
Well, they're cheap. They're cheap. They're cheap. Like, you pay less for a man on AdWords on Google than you do for a woman, because women make more purchases, which I thought was fascinating. I threw an example up just now on Twitter that people may want to look at on this as well, because I think there are a couple of interesting international examples here that we've seen. I'd point to, very briefly, to Caribbean telcos and the way mobile went into Caribbean, and I'd point to mobile banking in sub-Saharan Africa, both of which were examples of reverse innovation where the equity piece ended up playing out in a different way. And I'll wonder aloud, but not say it as a definitive statement, that I think the Babylon Rwandan Gates Foundation experiment bears a lot of watching, right? Because in a sub-Saharan African country without good access to primary care, it's turned out that augmented intelligence, particularly for nursing stations, has been hugely valuable as they rebuild their healthcare system. So I just caution on the equity point. I get it, I respect it, but I also caution that we have to really be nuanced about this and not just think about Western middle class medicine.
Do we have any more? Yeah, great.
Thank you, panelists. I wanted to ask you to comment on physician wellness and burnout and resiliency, because it seems to be a real focus right now in Canada around how tough doctors have it, and I'm sure nursing and pharmacy discussions are similar. Not that that should drive change, but I'm just wondering, I guess I'm interested, particularly perhaps from Stephen's experience, how these kinds of changes are affecting the experience of care providers in the system who we are thinking about a lot these days.
Yeah, look, I think that there's an interesting, I was on an interesting panel because there are about 20 students a year that get into University of Pennsylvania's medical school and Wharton. And until about 2 or 3 years ago, if they got into both, and you can assume they're pretty bright kids, 90% of them went to the medical school. Now it's reversed. So the panel was, is that a good thing or bad thing? I was the only one that argued it's actually a good thing. Because I think that the issue of why people are going into medicine is really a very important piece, and I think it contributes to burnout, and this is what I mean. I think there was a period of time in the 80s and 90s where going into medicine was, you know, I can be, especially in my country, I can become incredibly rich because I'm going to own my own nuclear medicine lab, et cetera, and I can make a few $1 million. In the American Medical Student Association, they talk about the E-road to success: emergency medicine, radiology, ophthalmology, anesthesiology, and dermatology. I have 2,000 applicants for my 6 dermatology slots and 300 applicants for my 20 family medicine slots. I don't think it's because everybody discovered the skin. I think that there's financial reasons. I think what's starting to happen now is that more and more students are going into medicine and nursing for the reasons that people at my era went to medicine and nursing. But here's the rub. I think because of that, that's contributing to the burnout. Because they're going in for the right reasons. I came in to heal, and that slide I had on capability, they're recognizing there's about 27 roadblocks between me and the patient. Some of it is regulation, some of it is, you know, the administrator, some of it is I don't really run even my own practice anymore. And what I really went into it for, which was that I would really have an interaction with a patient, is not happening. And when you get frustrated and you don't feel there's something you can do, and there's not that fun and collegiality, when we did a survey where we asked doctors that were over 45, what's changed the most in the last 15 years? The number one thing was fun and collegiality. And what's interesting about fun and collegiality is that's something I do have some control over. So I mean, what they said is we used to get together at the medical staff lounge and have, you know, bagels at 8 a.m. Now, because of all the regulations, we have to start our practice at 7 a.m. and the competition's so fierce, I don't want to have bagels with those other guys anyhow. So I think it's become a different piece. So here's the question. The question really becomes, how do we bring back fun and collegiality, and how do we use technology to decrease the barriers between the patient and the provider? Some of that I really do think the key to this is the EMRs. The EMRs have turned in, I call it the tyranny of the EMRs. If you want to worry about something ethically, Epic, you know, and Judy Faulkner is a friend, but Epic owns 70% of the records in the United States. It's a privately held company from one family. And the fact is that until recently, they've done everything they can so that you can't use anything that isn't Epic. Cerner's done the same thing. So it's a little bit like if I had a Mac 20 years ago, I couldn't put PowerPoint on my Mac because Steve Jobs didn't want any Microsoft products on the Mac, and vice versa. That's unsustainable. That's what we have. So I think part of what needs to happen is, as we partner with technology firms, is we have to have the mindset of how are we helping doctors and nurses get closer to a patient. If a technology isn't doing that, we need to reject it.
Here, here. You know, this user experience question in healthcare that Stevens has talked about, and the way we lost our way in the software world is just a fascinating question. I remember being so excited when President Obama put, you know, what was it, $32 billion into the pockets of Epic and Cerner and a few other companies. And what I don't think any of us saw at the time was the degree to which this big government-led move of technology took the specifications away from a patient and provider focus. And in some ways, it was a necessary process, I think, Stephen. We had to ram the technology in, and anyone who hasn't read Gawande's article on this in the last 2 weeks absolutely needs to. It's really, really great. And a colleague of mine just did an article. I interviewed him on the Canadian side of the same thing. It's on my Twitter feed. But this question of getting user experience back into these software systems, it's like got to be job one over the next decade. We got to make these things usable.
And by the way, it's inexcusable that the Affordable Care Act didn't include open source coding, because if it did that, I mean, it used to be, again, I'm old enough that if I had a Mac, I couldn't get on the same websites as you if you had, and then we said, hey, if the internet is going to go anyplace, we have to make it available to all. You could do the same thing with the MRs. I have a question. Do you have in Canada, do you have direct-to-consumer advertising with pharma?
Not the same way they
because
do
if you want to, this gets back to your ethical question. I was trying to figure out, in our country, whether it's the morning shows, whether it's Morning Joe or Fox and Friends or any of those, the #1 ad is this drug for stage 4 lung cancer. Now I'm thinking, all right, I understand ads for Advil or, something like that, because, lots of people, like how, well, it turns out there's a drug for stage 4 lung cancer that costs about $500,000. And there's best practice algorithms of when to use it. And what's happening is, because those patients are seeing it, they're going to their doctor and saying, oh, how come you're not giving me that drug? And they say, well, it said on the commercial that I could live longer. So the docs are saying, you talk about burnout, the docs are saying, wait, I'm following best practice. It's $500,000. It's not going to help this patient. But the heck with it. If the government's going to allow, them to do that, it's clearly that they've recognized that enough patients that don't need it will ask to get it and get that $500,000 drug. That's the only reason they have it. So I think that's where, when we talked about regulations or we talk about what government can do, that we have to start thinking about those unintended consequences.
Well, I think that while it's true that we have regulations here with regard to direct-to-patient advertising, with regard to restricted medicines, that is prescription-based or medical devices, the reality is we have full access to American television. And most Canadians can't distinguish among them. And so the very issues that Stephen has just described are part of the pressures on the Canadian medical health care system now, because they see exactly the same advertisements, and they want to live that extra 2.5 months.
And the reason you're not giving it to me is because of your Canadian health system. Right?
Absolutely. And so, so the issue, we've got to understand this open world we live in today, and the pressures that it's putting on the entire system.
I just want to ask do we have time for a few more questions? Perfect.
Thank you. My name is Bharat, and I'm an emergency physician. Will, I just wanted to echo what you said before, is that we can't wait for government to take a leadership in these matters. I think each and every one of us need to take that leadership in our own industry, in our own way. My question is a little bit more from a global perspective. We're working in an increasingly globally competitive environment where we're competing as nations. And so what is the impact this regulation is going to have on our competitiveness against a country, a communist dictatorship like China, where they're not going to have these ethical restraints in place? How is that going to impact our competitiveness in the global atmosphere that we live in?
So if I can't speak for Canada competing in terms of global competitiveness, but this is very much on the minds of Europeans. And so on this high-level expert group, we are having the discussion, do we want Europe to be competing with the United States and with China? The amount of money that they are investing in AI is exorbitant, and Europe is, investing, but can't come close to what China is doing. So of course you're going to have a brain drain. But what Europe is deciding to do, or at least within this community, we want to say that we want a different kind of approach to AI. We want an approach to AI that is accountable AI, trustworthy AI, based on human rights. So the Council of Europe, the Charter of Rights and Freedoms, that is the foundation for how we want these systems to be developed, to be implemented, and to be governed. So while the products from the United States and China might get to market faster, still we are at least trying, hoping that we can provide consumers with an alternative that is done with a different set of values in mind. That's at least what Europe is doing.
I think the second part of your question is actually a pretty scary thing. It gets back to your point about things like drones and robots in war. You know, I think as we start to develop things like gene splicing and literally looking at how can we prenatally affect a gene for Tay-Sachs or whatever, then that cat is out of the, you know, that cat is out of the bag in that, you know, countries that say, boy, I only want to have male babies, will start to use that technology for that kind of thing. There's no way of putting that back in the hole, and there's not much you can do about that. I think countries like exist in Europe, United States, and Canada will be smart enough, whether it's cloning or genomics, to say, hey, let's make sure, and we had a good discussion about that we and I love what you said, put that in the front, not in the back. But the technology is going to be out there. And just like the technology for, you know, the atom bomb didn't necessarily start with how can we bomb the heck out of a country. So I just think it's something we're going to have to watch and take some world action. Because we talk about government not being effective. I'm not sure the UN is necessarily ready for that kind of action either.
But that's also where certification programs and quality marks, they come into effect, so that when you are using a service that has AI, or you buy a product that, you know, is a robot, you can have some sort of visual representation of what was the accreditation system or the certification system behind the actual product.
Just to come back on the Canadian piece specifically, though, in terms of what we can do, and I know that this won't necessarily be a popular opinion, but we have to get over ourselves around healthcare for export. We saw with this Saudi training thing this summer how much we can impact worldwide healthcare if we do it in a responsible way. With the virtualization of services and with our excellent competitive market position, you know, our price for hips and knees is now 8,500 Canadian at downtown teaching hospitals, like crazy low relative to Detroit. We've got a competitive advantage.
Is this a paid advertisement?
No, I'm telling you, if we did,
because I'm going to need one soon.
If we did as much healthcare for export as we currently do education for export in this country, we would be looking at $60 to $70 billion to our GDP. And as the politicians are fond of saying, those are good, clean knowledge economy jobs. And if you want to make a difference worldwide on some of these issues, you get out there and provide good, ethical healthcare services to the rest of the world with the right value framework. I know that we have to figure out how we bring foreigners into our hospitals if we do that, but you want to have an impact on the world's healthcare, you got to get over the question of healthcare for export.
Okay, so I'm Zena. I think I'm the only health futurist in Canada, so I kind of hang out with the future and see what's happening. So just on China, just some facts for you guys. They're not just putting a few billions, like we're so proud of our Vector Institute, like total joke compared to what China's investing in AI and quantum. Multi-billion dollars to win in quantum. The center of gravity of innovation will all move there, and countries will decide, do they ally with China or do they ally with the West? Because the next Amazon is going to come from China, and that's where all of everything will drive. A couple other things on China, I think it comes to ethics. They're now, one of every 2 babies born by 2020 will have a whole genome sequenced. Today it's $200, that just happened this week. It'll be free. We have a committee to have a task force to make a report, to have a conference to talk about if we should do BRCA, for God's sake. On our population. So when you have all the data, UK's doing, I think, tens of thousands of genomes just announced. And then on embryo selection, they're now selecting embryos for eyes and other traits. And it's not just sex, it'll be sports, it'll be all these other things. And so this kind of global species conversation about this is gonna be absolutely vital. When, you guys know John Halomka? He's kind of went to China and he's like, oh, you guys are doing all this stuff in data. You should have a national identity. If we tried to have a national identity card for Canada, it's like a 30-year project, 6 months. One identity, whether you rent a bike or you go to the hospital. 6 months, they pulled it off. So I think we're kidding ourselves in Canada if we think we're going to navel gaze and just be relevant in the global economy, let alone competitive. And so my last comment, and I wonder what you guys think, is on kind of Canada's place in all this, I look at the Rwanda example. So in Rwanda, they're getting better primary care and urgent care using UK doctors than any of us are getting today, on demand within 65 seconds. So I think maybe our competitive advantage, because we tend to be 10 or 15 years behind everybody in modernizing healthcare, is maybe we kind of wait and see how this all plays out, and then like cherry pick all the best of everything, and then we leapfrog everybody else.
I think.
You know, but I don't want it to go, the China ruling the world thing, I don't want to just leave out there. I think that there's been lots of predictions like that. My Wharton final in 1996 was how Japan could not take over the world. Because if you think back, Japan was selling all the cars. They had this thing where every worker just cared. Japan was going to take over the world. We were all going to become subjects of Japan. And it didn't work out that way. And there's reasons that it didn't work out that way. What we have going for us, all the things that are sloppy in the United States and Canada, also bring the creativity and the discussion. And I would argue that what will start to happen is that as China, and my initial thing at Wharton was the free enterprise zones of Guangzhou and Shenzhen, what's going to happen is as those folks start to see more and more wealth, they're going to want some more and more of the stuff. They're not going to want to work as hard, and there will be a lot more pressure. So I think if we can channel our creativity in the West between Europe, Canada, and the United States, even with the sloppiness, and not just say, aren't we great, but really channel it and work across the West, I believe that there's opportunities for us to win. You know, we were dead in the car industry, dead in the 70s and the 80s with gas crisis. What got us out of it was creativity. It was the Chrysler minivans. It was the hybrids. It was the Teslas. So not everything is going to be in. Not everything's going to happen in China, I don't believe. They still can't make a car very well.
Yeah, Aimee, with all the ethical things you said, Aimee has to have
No, but I was
word.
just going to say one thing to keep in mind when we're comparing ourselves with China and how quickly they can move is that it's also a dictatorship, right? So it's a little bit of a different situation over there. Not as many red hoops to jump through. And then the other thing that I was going to say, going back to the genome data and the sequencing of the genome and stuff, just one thing that sort of pops up in a European context, right? In World War II, the Netherlands, the population of Jewish individuals in the Netherlands was one of the countries who kept meticulous records on religious affiliations, where people lived, and so on and so forth. And so it was really actually tragic that during World War II, the Nazis were able to come in and have this perfect record of everyone that they needed to fill in the blanks. Yeah. So yes, it is great to have these profilings, there are genomes, but the slowness, there is also some value to that. That sometimes we're thinking about the history of what it meant to have all of these details on record and easily accessible. That's all I wanted to say there.
Well, I think there are other factors here too. I don't take the political leadership issue as being the factor that's going to determine where the issues of China versus us. I think the social, economic issues are important and so on. But I was part of a small group of people who, the others, claim to have knowledge of what's going on in a number of countries, including China. And one of these international experts said that China has now claimed that they can detect from facial recognition in 4 seconds any one of 1.4 billion people. Now, what that tells you is not just that capability, but the fact that they've developed a technology that takes into consideration all of the racial, color, structural, and other considerations that we're worried about in terms of making it equitable, in terms of using facial recognition for entry to buildings, and so on. Because if you take across the entire Chinese population, there's virtually every characteristic that you can identify. That's a phenomenal advance over what others are capable of doing today. So I think we are in for a very dramatic kind of issue, and I think we shouldn't make simplistic conclusions of what will happen with China based on Japan versus China as an example because it was a very small country with a small diaspora. China is a huge country with an enormous population and a larger population spread around the world. And so in terms of racial background and direct. So I think it's going to be a complex issue is what I'm saying. I don't think that we can sit here and predict. But I want to leave you with a thought that has emerged during the conversation today with other areas that are ripe for a major disruption in major social organizations, and that's our universities. We heard a number of people say during this conference that, you know, well, the Krebs cycle, for example, how many, and you go to any conversation today and, you know, people will talk about, one professional or another will talk about why do they need to learn organic chemistry to do this, or why do they need to know that to do it. Virtually everything comes down, what did I learn at university and the fundamental characteristics that really has affected where I am today? And I'm talking about the core arts and science parts of the university. The professional schools are moving way ahead in terms of where they're doing innovative things and so on. And so I've been looking at, on the web, the strategic plans of a number of Canadian universities dealing with the core. I don't see any of them looking at some of the fundamental questions that have emerged, if you think about it, have emerged even just during this one-day conference in terms of what they're looking at down the road. I mean, they're basing on things like increasing their foreign student enrollment, they're into this and the kinds of things. You know, sure, they've been around for 1,000 years, but they could be Uberized very quickly in terms of those central cores if change doesn't occur there, and that'll affect all of us.
I like that word, Uberized. I haven't heard that before, but I think on that note we'll conclude, so I just would like a round of applause for all of these panelists.